is valuable. So good evening, one and all. Thank you for joining us, and Happy New Year to those that I haven't said that to yet. Heather, go to the next slide, please. We've got a very full agenda tonight, but I think a really good agenda. Dr. Fechner has joined us, and he's going to be talking about, does facial surgery replace aesthetic injectables? So that will be, as always, enjoyable and educational. Variety of other presenters. Dr. Finley will be talking about adverse event of self-injection of filler. We spent a fair amount of time on E&M coding with the changes that took place first of the year. So if you have questions, please queue them up. We've got a lot of really smart people on the line to help walk us through that, make sure we're doing that correctly. We're going to talk about the EMA pathology module go live, a MIPS update from Dr. Agbechi Gadek, and then the beloved COVID vaccine update. Meg will share that with us, and then some patient feedback. So a full agenda. So with that, I'll just jump right in. Since it's the start of the year, and next slide, please. It gives us an opportunity to welcome a new teammate. So Danielle Mulholland, our new Chief Human Resources Officer, joined us the first of the year. Super excited to have her with us. She's going to bring a lot of new perspectives for us and help us as we continue to grow. She spent her last 8 years as the VP of HR for Stewart Healthcare, our medical group. So we're really excited. We like to have our symbol there of welcome with the handshake, but we all know, do not shake hands. A virtual high five will do. Next slide, please. You know, it's a busy slide. I'm not going to go through any of this, but I just was reflecting on 2020 and what a blur it was. Such a different year than I think any of us ever expected. But I think it's also helpful to take a step back and look at the year and then think about what we actually accomplished with the tremendous headwinds of COVID in our face. Ultimately, we provided a very safe environment for our patients to be treated, and we treated a lot of patients. We'll be talking later about how they appreciated that and their feedback, which has been really, really solid and strong and supportive. But just reflecting on the year from back in March, when this thing really roared its ugly head and we had to close operations and really rebuild everything with a different safety view. And we had to continue to morph that and evolve that as we learned about the disease and the disease evolved. Really great that we got back to all services in June and then have continued to ramp up and provide that access to patients the way we like to and provide the services we like to. We can even, in spite of that, we continue to grow. So we hired 15 new providers in 2020. But I always like to just think about that because we talked about all the challenges and the hard work and the different things we had to do that weren't normal, and really appreciative of all that helped do that. But we accomplished a lot and we provided great care for our patients, which is tremendous. And everybody on this call, everybody in the whole organization deserves a round of applause for that. And our patients truly do appreciate that. If you go to the next slide, you know, we began a new tracking tool in August, so you can see the future appointments. Patients continue to look for us to provide their care. You know, we had a little dip there around the holidays to be expected, but it continues to go up. So that is a real encouraging and great to see the way the patients trust their care with all of you. Next slide, please. So we have had a number of teammates test positive, but the group continues to make sure we have safe environment. So first off, I want to shout out the COVID committee. Those that don't know, but we do have a group of people that meet once a week and think about all of the issues and changes and scour the data that's out there to make sure we are doing things in the safest fashion. I just want to specifically call out Renee, who's been doing a lot of work as we have had, as I mentioned, some teammates test positive, Dr. Agbechi Gadek, Meg, Angela, all the practice managers, and certainly the whole COVID team. What I really like about this is the fact that, yes, we've had some teammates test positive. We have had 0 interoffice spread. And that just goes to the adherence to our policies that everyone is doing and following the right protocol And as painful as it is, doing the right thing, you know, wearing the mask, washing your hands, socially distancing, reminding people when they don't follow protocol or when you see an opportunity to enhance things. So I really do appreciate it. I know our patients appreciate it, and the results are very strong in that we have a very safe environment. So thank you all for all that you do. And with that, I would like to introduce our guest speaker, Dr. Fechner. And with that, I will turn it over to you. And I don't know if yeah, you're going to flip the deck. So great. Welcome, Dr. Fechner. Thanks for joining us.
Yeah, thank you very much, Rich, and thank you for having me. Happy New Year to everybody. If some of you may not know me, Frank Fechner, I'm a facial plastic surgeon. I practice in Worcester, Massachusetts, and I focus a lot of what I do on facial rejuvenation surgery. I hope this projects well for everybody. I kind of shortened the title a little bit to fillers or facelift. Really at the end, I want to kind of share with you some of the challenges that all of us face when treating cosmetic patients. And just to give you the answer up front, it's not one or the other. It's not fillers or facelift. It's both of them are really complementary in our overall quest to try to take care of our patients' goal for personal betterment and improvement of their self-image. Let me start off by showing you this patient who is after facial rejuvenation. And I think most of us would agree that she has a desirable result after all. She had a comprehensive facial surgery, but not only. She, in addition, also had, after her surgery, filler treatments. She never had any injectables before. And really the common observation that I have that virtually all patients today, after their surgery, also continue with further treatments because they truly want to maintain of what they achieved with the surgery. And that's a big difference to just even 10 years ago, when it was for many people one or the other, and now it's really both of them. Same patient in the frontal view. And really at the end, it's all about patient satisfaction, right? If I'm very happy with what I did for this patient, but she's not, I really failed. So gauging this desire and really gauging of what the patient is looking for and how we can achieve that for the patient is one of the most challenging problems that I face in my practice. In my observation, it is that probably about more than 90% of patients are satisfied with what we do, in addition to also the doctor being satisfied. Then, in addition, there's a smaller group of patients that is actually very satisfied, but if I critically evaluate, I'm not really quite happy with what I was able to accomplish. And then there's another group of patients where we may be happy with the outcome, but the patient is not. And these are obviously this 1% of patients or 2% of patients or whatever the number may be. These are the patients that really keep us up at night and cause probably 95% of the stress in aesthetic practice. At the end, you know, aging still is an enigma for me. And if you look at these two women, they're probably about 5 decades apart. It is amazing what time and environmental factors do to the face. And it's not really obviously one aspect that changed here. These are not the same people, but we can imagine that the lady on the right at one point looked somewhat similar to the model on the left. It's really a whole different aspects that changed, right? The skin surface obviously aged with wrinkles, development, texture changes, skin redundancy develops, in addition to laxity of the soft tissues. And also the distribution of fat changes quite a bit. We call it facial lipodystrophy, right? In certain areas we gain fat access, in others we lose it. But we also learned over the last 10 years plus that the facial skeleton, the underlying skeleton, is not stagnant, it changes also. And then also changes that are related to animation, like dynamic wrinkles and the like, play a role. And all of that can obviously not correct it with one treatment only. That's why it's really the complementary treatments that makes all the difference. And fillers certainly play a significant role in that, in addition to surgery. What is a youthful looking face? Well, you know, we know it when we see it, right? But really at the end, it's kind of the combination of soft arches with only very little valleys. We don't want to see much hollowness and sunkenness. We like nice light reflections in the cheeks and the underbrow area of the chin, and really soft transitions between all these areas. And in a perfect world, we wanna have symmetry. Nobody, by the way, is totally symmetrical, and I point that out to all of my patients, because invariably after their treatment, whether it was surgical or non-surgically, patients are going to find all the new asymmetries that they never took note of before. The aesthetic patient that all of us see, really the first stepping stone for virtually everybody is really relies on non-surgical treatments, right? And that's injectables, including, of course, all the different fillers that we have in our armamentarium, Botox injections, and other skin treatments, whether it may be chemical peels or power device related treatments. Virtually all patients start with that. Nowadays, I don't think I have, over the last 2 years, seen a patient that did not have non-invasive, non-surgical treatments done before they come and see me for the potential surgical treatment. And again, that's a total difference just over a 10 years period of time. But then all of these patients that I see and that you may see, that brings challenges with it, right? With direct-to-consumer marketing, we see patients who come in and they say, well, you know, doctor, the filler worked great the first time, but I don't think the second time the filler took. I'm not sure whether you hear this. I hear this a lot. And I think the reason behind that is multifold. On one hand, if you're able to improve an area of concern with the first filler treatment by about 30%, we cannot expect that with 3 more treatments, suddenly you're at a 90% rejuvenation, right? It's the further improvement with another injectable is not as much as the first time around. And the same I have also observed with Botox. But it's a common scenario that I think is also leads to what we call kind of filler fatigue. And then if a patient continues to bring this up and kind of in a gentle way complain about that they're not quite happy, then that can also lead to kind of fatigue of us providers. And then another response I get from patients after non-surgical injectable treatments is, but I see all of this. I see all of this still, and for some reason, people nowadays believe that with a needle you turn into a magician and you can really kind of eradicate what 30 or 40 years of aging brought about. And of course, we can't, but the expectation nowadays is very different. I don't know whether it's social media related, that patients see all of these brushed up photos, before and after photos that are maybe not quite based on reality, but expectations certainly have increased quite dramatically over the last years. And then patients who come and said, well, I think I need a little bit more. And you look at the person and you're going like, really? I don't really think that you need anything. Definitely not in terms of injectables. But with every treatment, we reset the patient's self-image in some ways. And I think it relies on us to kind of guide the patient towards the question whether there should really be more treatment done or not. And it causes a significant problem because on one hand, you want to help the patient, but the best help I can give them is probably not injecting more. But if we don't have a very strong relationship with the patient, I can promise you that they're going to go somewhere else. And I promise you that that other place will definitely inject 1 or 2 vials into their face, even if there's not a good place to put it. And really, if that happens, then we really haven't served the patient at all, right? We have not helped them to improve the overall aesthetics, and you lost the patient, and potentially the patient lost trust in us if we cannot guide them appropriately. So it can be a very, very tricky situation that I don't know whether some of you face that, but I sometimes do. So that's when the discussion of surgery may come into play. And I do think it's important for all of us to have some understanding of surgery. Of course, the first time around, you mentioned it, the patient is just going to be scared. No way. I don't want that. I want to look good, but I don't want to look weird. But if for everybody who comes and sees me for facial rejuvenation surgery, that is nothing that they've just started thinking about a week ago, right? That is really a process that most of my patients go through over at least a five-year time period. It's something that really has to kind of sink in. But if we are able to communicate slowly and carefully that, yes, there is still surgery and there's still a role for that, on one hand, it does provide patients with a certain amount of hope that if in doubt, there's something else one can do. We at the same time care for them. We're not going to push them into surgery, but we tell them, well, that's certainly an option, and then we don't have to continue maybe with treatments that may be slowly going in the wrong direction. And it also shows a certain amount of care and trust that the patient has to develop over time in us. But then there are patients that I see that they say, well, let me just wait a little bit more because I hear about all these new technologies that come on board, and I think surgery is not for me because there's something going to be better that just will achieve the same results. Well, I can tell you that with 100% certainty, I know that in my personal professional lifetime, a facelift will not be replaced with non-surgical technologies. Technologies will continue to come about, but nothing will really replace surgery. And before I kind of show you a little bit more of why I think that's the case by actually demonstrating what we really do with surgery, I want to just show you some of the approach I take for my patients when I assess them for surgical treatment. So it's really at the end what we want to do with aesthetic treatments. We want to improve the surface anatomy, right? We want to correct some of the volume deficits that patients develop in their very individual way. Many of them lose volume in the temple area, the under eye area, in the malar region, nasolabial creases and canine fossa, and the prejowl and marionette lines. All of these areas can be very effectively treated with injectable fillers. In fact, as I mentioned, most of my patients had fillers injected in these areas. And for surgery, I virtually never remove them. The only area where I actually remove the filler before I go ahead with surgery is in the tear trough under area, because that's something where I like to do, I really like to have a clean slate without fillers in place. And then there are areas of volume access, right? And that's also in the under area, in the lower cheek area, and the jowl area, and in the neck area. And that can be corrected with the help of liposuction, with direct excision, or with repositioning through surgical maneuvers. And this is a patient now before and after. And if we observe her closely, I think that she has a nice improvement after her surgery, but she's not completely corrected, right? There's still opportunities for further improvement with fillers. So I see certainly an opportunity here for filler enhancement in the malar area, in the canine fossa nasolabial crease area, and in the areas of the marionette lines and prejowl. She actually did go on and have these areas treated. I unfortunately don't have photos of that, but certainly this is a routine, what I see in my patients, that they will continue with their injectables that they started already before surgery. Another patient example, before and after. Now, she had, after her facial rejuvenation surgery, she had injectable fillers in order to really give her that result, because you can, I think, notice the improved volume in her cheeks as well as in the prejowl area. So let me take you through the process of a facelift, and I think it's kind of interesting to see this. Number two, it also shows you of what actually is done, and imagine how a non-surgical device may replicate some of that. So of course, everything starts with planning, and I like to do the planning really on the patient's face. And what many patients are concerned before surgery is the scar. It's interesting. People don't really talk about it, about the scar afterwards, but that's certainly a big concern beforehand, because nobody wants to have an aesthetic treatment done and then end up with scarring. So let me show you how I designed that. So the incision really starts within the sideburn, and then it follows the normal curve and reflection of the ear. I place it right at the edge of the tragus, and then I go around the earlobe. I place it in the back ear crease, and then actually I go along the hairline in a way that hair starts growing through the incision line. And the reason for that is that I don't want to create a step off in the back of the ear, because women like to wear their hair up, and this would be kind of it would scream facelift afterwards. So this is kind of the design before, and what I do then intrasurgically, the area that is here shaded in yellow, I raise a skin flap. So this is just a skin dissection, and then I transition at the line from the cheek to just in front of the angle of the jaw into what is called a deep plane. And the reason that I transition there into what we call the deep plane, it's a little bit more work and it's a little bit more technical, but I'm actually able to release certain ligaments in the malar area and also along the buccal cheek area, which then allows me to reposition the midface area in a more comprehensive and harmonious way. Otherwise, it's we see kind of these patients that look tight along the jawline, but it doesn't match the midface. So intra-op, this is how it looks after this dissection has happened, right? I have here in my forceps, the area where I transitioned from the skin flap to the deep plane. And I want to show you, and now I'm underneath what is called the SMAS, and I show here with my forceps and how far I dissected forward in order to really mobilize everything. Because if we mobilize it well, then I can reposition the tissues rather than relying on tension. Tension is not good, it's unnatural. Repositioning really leads to the most kind of harmonious and elegant look afterwards. So here I use an absorbable suture, this is a PDS suture. All the sutures I use are absorbable, and you can see the amount of mobilization in the mid phase I get by actually releasing these ligaments that that I've described before. Once all that repositioning has been completed, this is what it looks like, right? I now have excess skin. And again, I don't want to rely with my lift on skin tension. That only leads to poor scarring and does not hold up over time. My patients are looking for long-lasting benefits when they go through surgery like that. They don't want to have something that only looks good for a couple of months. And so all the skin trimming is now done so that the skin lies exactly at the skin edge. I don't want any gap there because that to me guarantees best healing, right? And this is what it looks like after everything has been sutured up. So let me show you a couple of patient examples. So this is a lady who came in just after we opened up again. She actually owns a medical spa, and she has a face full of fillers. But at one point, she kind of realized that she doesn't get what she was hoping for with filler treatments. So this is her after 6 days. For her, we did a lower face and neck lift and a lip lift. Now, she probably is a little bit of ahead of the curve in terms of day 6. There are certainly some patients that have more puffiness and more bruising at this point. But obviously, normally we don't take photos on day 6, right? But it's still good to know what patients look like after that time period. On day 6, patients come for suture removal for us. And this is her then after 6 weeks. 6 weeks is healing is not complete. There's still a little bit of plumpness and puffiness remaining in her face, but certainly our patients are presentable at this point. 3/4 view, similar idea. Before at 6 days, you can see the slowly resolving ecchymosis and still that kind of unnatural look there. And then after 6 weeks, she looks normal and certainly presentable. Another patient who's 6 weeks after surgery, and I don't know whether you can notice on the patient on the after photo, she is not happy with me. She comes with a list of about 25 questions, complaints, problems. And that is one of the hardest issues, is that before surgery, she appeared absolutely fit for the surgical procedure and also fit for the recovery. But during the recovery, she, I don't want to say she decompensated, but she certainly faced a lot of challenges of going through the emotional roller coaster, right? And that can be very taxing for a patient. I noticed that during COVID now, it makes it easier for patients to commit to surgery. We have a lot of patients inquiring and actually going forward because it is relatively easy for patients to hide the key parts of their faces with masks and working from home and their like. but it doesn't make the recovery process easier because there's less family support. Many of our patients try to struggle through the recovery by themselves, which is never a good idea. It's good to have a good support structure in place. And then you never know how a patient will really respond in such a stressful situation, because after all, going through a facelift is a life event. So it's a totally different experience than going through a filler treatment. And you may even see sometimes a patient where even going through a filler treatment is challenging, but imagine going through surgery. It's something that I do not take lightly, and we try to prepare our patients for as good as possible, but they are obviously the ones that are going through them. We talk to her throughout the recovery, probably the first 2 weeks, between twice a day, usually twice a day. We talk to this patient, and now at 6 weeks, she actually, I think to me she looks good, but she's beside herself and does not like anything at the moment. So just one of the challenges that we face. And that's a patient example when everything is kind of healed in place 12 months after surgery. Of course, not everything is corrected. She also is still going through her annual injectable treatments for maintenance. But really what the surgery achieves is you're able to provide the patient with a significant improvement upon which you can build with further non-surgical treatments. And it is important for the patient to know that after surgery that they should not just go back to their normal habits and maybe go to the beach without sun protection, but maintenance is important. Luckily, it is much easier to convince patients in the importance of something simple as sun protection, because they're invested so much into their face, and their natural drive is certainly to wanting to maintain what they are invested so much in, not just money, but also time and stress. Yeah. So these are a couple of thoughts that I had on the whole topic. I love what I do, and I think that at the end, these kind of treatments are of utmost importance to the patients. It is a sign of huge trust if a patient actually goes through this with us. But that's kind of what we do. That's what we specialize on. And we have everything kind of set up in my practice to give the patient the best experience. We have a fully accredited surgical center. I'm located here in Worcester, Mass. So all of our patients have their surgery done on site. Everything is done on an outpatient basis. Many patients who come from further than about 45 minutes drive away, they're spent usually the night before, and the night after they're spent in a hotel down the street, because I will see them the day after surgery. And then they don't spend hours on the highway and the time when they really just want to take it easy at home or in a more comfortable setting. So I don't know whether there are any questions, whether there's an opportunity for questions, but yeah.
Well, Dr. Fechner, thank you very much. You're always interesting to get your perspective on things. I didn't probably do a great job of introducing you to the broader group of people who don't know you, but Dr. Fechner has been a friend to AP Derm for years and years and years, and he regularly joins us to share some different perspectives. So that's awesome. We do have a minute or two for questions. If there's any questions, Mark or Heather, could you just remind people how to ask a question, and we'll address those?
Sure. If you bring your mouse to the bottom of the screen, you can raise your hand, or you can type a question into the Q&A box.
Did I shock everybody?
Well, those are pretty amazing before and after pictures. It's very, very fascinating. So, all right. Well, if somebody thinks of a question later, we can always circle back with you, Dr. Fechner. As always, appreciate your time and all that you do, and thanks for joining us.
Thank you so much for having me. Have a fun meeting, everybody.
Thank you. So let me turn it over to Dr. Finley, who will talk about adverse event after self-injection of filler. Dr. Finley?
All right, can you hear me?
Yes.
All right, excellent. Thanks so much for having me tonight. I think this is a good kind of case report to come after that talk. This was something that I hope I never see again, but it was a real learning experience for me. So we can go to the next slide. Do I have control over that, or no? I'll just prompt you, I guess. So special thanks to two people, Diana Fairfax, one of our nurse practitioners at the North Attleboro office. She alerted me to this case. She's a great clinician, knew something wasn't right. And so she was the one that made the call to me that this was something I needed to come in and see. Immediately when I saw the patient, I called my mentor, Paula Moskowitz, who is just a cosmetic guru, and I'm not sure I would have survived this without. So moving along, the case presentation. So this is a 62-year-old, relatively healthy female, a very former distant smoker. She's actually a practicing oncology nurse. She is known to me, prior Mohs patient, but I had never seen her for any cosmetic procedures. This all kind of happened in June of 2020. So she presented to our office in an acute visit setting with Diana. I believe it was for a rash on the forehead. Diana obviously appropriately knew something quite wasn't right, was not getting a full history from the patient. Once I got to the office, she kind of divulged a little bit more. And so on Saturday, June 6th, she had decided to order this filler that you see. This is actually the exact filler that she had bought a couple vials of. She had decided to inject her upper lip, her nasolabial folds, glabella, and forehead with what she called a superficial injection. And she used up to 2 to 3 syringes of filler at that session on Saturday. So moving ahead, her immediate kind of symptoms and sequelae were that she instantly noticed on the forehead when she was injecting the glabella and forehead that she had a white vertical linear streak. She said it quickly became blue like a bruise. Very quickly then developed redness and a very intense pain. She said it was like a burning pain, like her skin was coming off. She denied at any point visual changes or symptoms, and she stated that she had a very mild headache. So again, I was called by her nurse practitioner. So this was the following Wednesday. So she injected on Saturday, had kind of been dealing with this on her own. This is her presenting, one of her presenting photos. Again, she's having intense pain that's radiating throughout the forehead, inferiorly to the brow, as well as up onto the frontal scalp. Again, had absolutely no vision changes. And just a couple more photos just to follow, which are just really quite striking. We soon were able to elicit a history from her. This image was, of course, immediately, I think, what most surgeons. I'm trained in cosmetics. I worked with Dr. Moskowitz in my training. certainly, this was just something that I never thought I would see, just a distribution of a, quote unquote rash in, as you can see in the diagram, the supratrochlear artery. It's an artery that us Mohs surgeons know very well when we do forehead flaps. And then of course the supraorbital, which is more lateral, but this is just in a striking supratrochlear distribution. So this was kind of the image that was in my head. Moving to the next slide. So like I said, I called Dr. Moskowitz right away. I kind of knew what I was seeing, but I wanted to be sure. She did give the full history to me at that time. She simply said that she had done it before, and this is something that her and her friends do, which was totally shocking to me. Dr. Moskowitz was kind of talking me through it, and she also kind of on my behalf posted on a board certified dermatology group on Facebook, which was just really, really helpful to get people's opinions on how to manage this. Moving forward, the article that really was kind of the most important to me in managing this lady was this very article right here. And this is something, again, Dr. Moskowitz pointed me in the right direction. So this is basically a article regarding a protocol of kind of a new way of dressing possible ischemic events and emboli in the setting of filler injections. The protocol, however, was used when it was implemented within 2 days of a known ischemic event. So clearly she injected Saturday. I was seeing her on Wednesday. She was outside of this window. So I wasn't sure if any of this would work. The protocol calls for injecting very high doses of hyaluronic acid into the tissue hourly until you're clinically seeing resolution, that being defined by an absence of pain, which I think is probably arguably the most important, as well as skin color and then the capillary refill. And the protocol basically calls to flood the tissue, pushing the enzyme into the capillary beds. So the next slide is just a table from that article, a couple slides just straight from that article. Basically, they're saying their new protocol here compared to traditionally how these events were managed. So basically, the immediate timing of injecting the enzyme into the tissue is stable with both. The dosing strategy, they were calling for basically a variable amount to be injected based on the volume of tissue affected. So for somebody like this, where you're really seeing kind of that whole course of the artery on the forehead, they would call for quite a lot of flooding of the tissue. Again, they suggested that you do this hourly until you're starting to see resolution of those symptoms, versus traditionally that may have been done daily or more spaced out. The idea behind this newer protocol was that you really wouldn't have to then pursue any ancillary treatments. Whereas with the traditional one, you were also kind of thinking about application of vasodilators, hyperbaric oxygen, et cetera. And in the couple cases that they cited in this new protocol, they had a great resolution. But traditionally, depending on the onset and the treatment administered, you can definitely get scarring and long-term changes in the skin. And of course, the worst outcome would be vision loss, blindness, which fortunately our patient here never had any visual symptoms. So this next slide is quite wordy, so I apologize for that. But I thought it was important because basically, if you're going to flood the tissue with hyaluronidase, then you have to make some assumptions on how that is going to work. So as you can see here, so basically you're making the assumption that the ischemia is related to obstruction by the filler inside the artery. That by flooding the tissues, you're going to basically relieve that obstruction so that you resume normal blood flow. that the fillers, as you're treating it, will break down into smaller and smaller pieces, and then allowing that to basically pass through the capillaries and blood flow to resume to normal. There are different ways when you inject the hyaluronidase into tissue that it's kind of immediately deactivated and diffuses out. And I'll kind of revisit this in a minute. But the whole idea behind flooding tissue is that the immediate injection of the hyaluronidase, you're already losing some of it. So you want to just kind of keep pounding the tissue with it. And it kind of goes on just with basically the ideas behind flooding the tissue. So I think we can move forward because that's quite a busy table. A couple like helpful diagrams I thought when I was looking through this article and trying to come up with how I was going to treat her. I think the key is that the theory is that in the second picture is that once you inject the hyaluronidase, it's kind of immediately leaving the site, whether it's just serum leakage, so it's dilution, deactivation by the body, or just diffusion out. So again, you just really want to push as much through as you can. This is very interesting, the next picture, because this is again straight from the article. And basically the take-home message for this is that the thought is that people are higher risk for vascular events when they're injecting filler, and hitting an artery, particularly in people that have had multiple filler injections, because it creates scar tissue from the prior injections. The idea is that it kind of creates a path of least resistance, so that filler can kind of escape back into the artery and then can cause the occlusion via that. Moving forward back to our case. So basically, we kind of came to the conclusion, and again, just want to thank AP Derm for this, because they really mobilized a lot of vials of the hyaluronidase for us, which were not super easy to come by. This was something where, again, just a lot of conversation in the moment with Dr. Moskowitz, and then it was just a lot of responses on this Facebook group, which was really, really quite helpful. Uniformly, everybody said just, even though we're out of the 2-day window, just flood the tissue, and may or may not see relief in pain and other clinical improvement, but everybody basically said it's worth a shot. So immediately when I saw her that afternoon, evening, I did inject 2 vials. They're 600 milligram Hyaluronex injections. She actually described relief in some of the discomfort within 30 minutes. So I felt like that was reassuring. I gave her mupirocin to use. And at that point, I mean, honestly, I felt like sleeping beside her with a monitor because I was so nervous about what was going to happen with her. But we agreed to, she had my cell phone. She kept me posted how she was doing throughout the night. She said she was having an incredible relief and discomfort. I met her again at the clinic that morning at 5 a.m. and again injected 2 more vials of the hyaluronidase. I also discussed with her that I thought it was important, because she was outside of the recommended treatment window in the article, that we at least make a referral to a wound clinic for consideration of wound care and hyperbaric oxygen. So again, the next morning, on the next slide, she had described immediate relief and pain. I did flood her with another 2 vials. I really wasn't quite sure what I was doing. I obviously knew the distribution of the artery, and so I tried to go for an entry point there, but again, just really flooded the tissue. I really didn't clinically see too much happening, but again, the relief and pain was reassuring. She, right after that, went to the wound clinic. Again, this was quite a learning experience. We sent her to the wound clinic with obviously the history of what had happened. However, she was seen by a nurse practitioner at the wound clinic who really didn't kind of understand what had happened. So they actually just sent her home before they called me with some silver nitrate and basically said hyperbaric oxygen wouldn't be considered because it would not be reasonable to pursue this in this case, and also it would be not affordable in any way for her without any kind of imaging to actually document that there was an occlusion in the artery. So I was certainly discouraged. She came back to me the next slide that afternoon and kind of reported all of that to me. I thought she was looking perhaps a little bit better. She was in much less discomfort, but she still looked very dusky to me, which I was concerned about. Again, still had absolutely no visual symptoms and otherwise felt fine. So on to the next slide, at 3 p.m. So I'd seen her the evening before, 5 a.m. that morning, and then at around 3 p.m. later that day. And I again flooded it with another 2 vials. It was quite expensive for her. Again, I kind of polled the people on Facebook and asked, what people would charge for this. And again, I was charging her $500 for a vial. So it was, at considerable cost, but I really felt like she was improving in terms of pain, and so that it was worth it. Moving to the next one, from that point on, I was just kind of determined, again, we're outside of the treatment window. She's somewhat improving, but I was still very nervous about what I was seeing. And also talked to Dr. Moskowitz, and we just felt like referring her for consideration of hyperbaric oxygen was probably what's best. So I originally had sent her to Tufts to find out that they did not have a hyperbaric oxygen chamber. So I spent much of that night. She actually drove from the time I injected the last 2 vials. She drove straight to Boston, and I was on the phone with Tufts, and then finally got her referred to MGH. You can imagine talking to an ER attending about what was going on was a little tricky because they just weren't totally familiar with self-injection of filler and supratrochlear artery and occlusion and all of that. I was able to get her the following morning to Dr. Goudiam and spoke to her at MGH, and they were absolutely superb. She administered 2 hyperbaric oxygen treatments within 48 hours. And then she was scheduled to follow up back at MGH within 3 days. And at this point, she was pain-free. I saw her the next time, for the next slide, on June 24th. So now we're obviously several days after, and this was her appearance at that time. She was completely pain-free, very, very pleased with her cosmetic outcomes so far. She was using a silicone bandage, and I did offer her some V-beam to clean up the redness, which she declined because she was very thrilled. I think it was at this point that I felt like I finally kind of reached her. She's a very lovely woman, but I just don't think she understood the gravity of kind of the potential of where this could have gone until this visit. And she actually got very tearful at this visit, was very appreciative, and it was really made it all very worth it. Just a quick note, and then I'm done. The next slide, I think I was completely blown away at how easy it is to get these products and how common this may be. So this is actually the product that she brought in and showed to us. So $64.99 on Amazon. Kind of hilarious because I'm looking at this and I'm thinking I really know the zip code 37919, and that's where I grew up. But all you have to do is do a quick search and you see all these injectables. And I mean, you can get Botox injectables from all over the place. Some of them say they're shipping from within the United States, from the Ukraine. It's so variable. They have all kinds of promotions where, you get free shipping, and they're all kind of sponsored and, supported by various non-MD centers. So microblading, med spas, beauty salons. There was like a Contoured Beauty, a Face by Desiree, all these different centers and places that sponsor them. So I think this was just really eye-opening for me. Again, she said that she knows so many people that do this, and I think, again, she did learn her lesson, and I'm hoping that as a nurse, she's an advocate for herself and warning other people not to get themselves into this situation, but it was completely eye-opening for me. So, and that's it. I had texted her, I did ask for permission to obviously present this, and she very willingly said that she would love for me to do so. I did speak with her about 2 weeks ago, and she's doing wonderfully. She said she has barely any redness on the forehead, and she's doing great. So that's that.
Awesome. Well, thank you very much. I really appreciate that. Very fascinating case, and the patient was lucky that you were there for her. We have a comment. Wow, bravo on all your hard work for this patient. What an incredible impact you made in such a challenging case.
Thank you.